Hello students, this is Eswara Karteek, Professor, Department Pediatric and Preventive Dentistry, Vinaga Mission Stankaracharya Dental College, VMRF DU. Today's topic is stainless steel crowns. Coming to the introduction, maintenance of the primary tooth is very important nowadays. So it shows that healthy condition, overall well-being of the child. So treatment of the severely destructed tooth is stays on three factors which should be kept in mind. First one is behavior management, preservation of tooth structure and parental satisfaction. Coming to the stainless steel crown history, this stainless steel crowns has been used approximately over 50 years. So these stainless steel crowns first described by Engel in 1950, followed by Humphrey. So later in 1970, initial crown preparation was suggested by Mink and Bennett. So after that in 1977, McEvery advised the modification of stainless steel crowns. Next, coming to the classification of the preformed crowns. So here according to the materials used and location. So according to the material used, stainless steel crown, nickel chromium crowns, aluminum crowns, tin silver alloy crowns, and polycarbonate crowns and pedo strip crowns. So according to the location, crowns of anterior and posterior teeth. So next, coming to the classification based on the composition, stainless steel crown, nickel based crowns, tin based crowns, aluminum based crowns. So composition of the stainless steel crowns, there are two compositions of the stainless steel crowns. One is based on the iron content and one is based on the nickel content. So first, coming to the stainless steel crowns, which is also called as 18H authentic steel type. So in that composition is chromium 17 to 19%, nickel 10 to 13%, iron is 67% and 4% of minor elements. Next, coming to the nickel based crowns, which is having nickel 72%, 16% of chromium, 6 to 10% of iron, 0.04% of the carbon, manganese is 0.035 and silicon is 0.2%. So the term stainless steel is used when chromium content exceeds 11% and is generally ranged from 12 to 30%. So why it is called as 18.8 authentic steel? So SS crowns contained about 18% chromium and 8% nickel. That's why it is called as the 18.8 stainless steel. So next, coming to the classification based on morphology. There are three types of according to the form and contour. First one is untrimmed, pre-trimmed and pre-contoured. Coming to the untrimmed, it is example is Rocky Mountain type of crowns. It is neither trimmed nor contoured, which is longer, lot of adaptation is required. It is a time consuming process. So coming to the pre-trimmed crowns, that example is Unitech stainless steel crowns and 3M and De Novo type crowns. So in this it is straight non-contoured sides but shorter, which is festooned and required contouring. So third one is pre-contoured crowns. Example is nickel chromium crowns, Unitech stainless steel crowns and 3M crowns. So these are festooned, pre-contoured and pre-trimmed. So here these crowns required only minimal amount of the adjustment which is necessary. So classification based on occlusal anatomy. It is divided into Rocky Mountain, which is occlusally small, Armaco type of crowns which is smallest and least occlusally carved, and Icon crowns which is compact occlusal anatomy, and Unitech which is shallow occlusal anatomy, and 3M it is ideal occlusal anatomy. Coming to the indication for the primary molar teeth, it should be indicated after the pulp therapy for multi-surface caries, patients who are at high risk, and fractured teeth with extensive care which is bruxism, and abutment for space maintainer where the restoration is likely to fail. So according to the Pinkerton, the children who are likely to attend regular recall appointments and who are unlikely to be reliable preventive patients. This is also a indication which was given in 2001. So indications for the permanent tooth. So interim restorations of a broke down of traumatized tooth, teeth with developmental defect when financial considerations are concerned, and restorations of a permanent molar which requires full coverage but which is partially erupted, young permanent molars which following endodontic treatment. So indications for the anterior primary teeth, first one is interim restoration of a traumatized tooth when financial considerations are a concern, and morphological and occlusal considerations. Coming to the contraindications, patients with nickel allergy is contraindicated, tooth with non-restorable and severely broken tooth as a permanent restoration in the permanent teeth, primary teeth exhibiting half of the root resorption, primary tooth with approaching exfoliation, restorable tooth by conventional measures. Advantages: the lifespan is the same intact to the primary tooth. The protection to the residual structure that may have be weakened after excessive caries removal. This one is a technique sensitive and application is low, whereas when we see in the long term procedure, it is a cost effective, which is good. So low failure rate and modifiability and fit. So disadvantages are like unsightly metallic appearance will be there, and gingival hypoplasia. In cases of gingival hypoplasia, so we can't give this, and cannot be used when the tooth is partially erupted. So armamentarium required for this stainless steel crowns are like crowns, different kinds of crowns. We have like kids crowns or primary anterior tooth and permanent tooth. Kit we will take first. Then burrs and stones, number 169L or number 69 FG. FG is fiction grip. So number 6 or number 8 RA, that is right angled latch type burr. So number 330 FG and tapered diamond FG, round burr, long thin tapered or flame shaped diamond burr, greenstone rough polishing wheel, and wire wheel for finishing crown. So these are the different burrs we will use. So WR13, F425 and TF21F. So other armamentarium required are like pliers and crown cutting scissors. Pliers like O pliers, that is 110 plier, and contouring plier, it is 114 Johnson contouring plier, and crimping plier, that is 417 crimping plier. Sometimes we will use this ball and socket plier, which is 112. So coming to the stainless steel crown case selection. So while we select a case of a stainless steel crown, so there are 4 important factors which we have to keep in mind. So patient behavioral management, dental age, and preservation of the tooth structure, and parental motivation and satisfaction. Coming to the technique, so first we have to evaluate the preoperative occlusion. So after that we have to select a crown, tooth preparation of anterior and whether it might be anterior or posterior, final adaptation of the crown, finishing, polishing, and after that we have to see the crown fit, and followed by final cementation of the crown. So we will see book reviews of steps of the tooth preparation. So first coming to the aspect that according to different authors, the occlusal reduction is minimal is 1, so 1 to 1.5 mm. So we have to break the contact according to all authors, and the marginal preparation, in that we have to round in the margins, and buccolingual reduction, there is no reduction required according to few others. Only Nikhil said it is 0.5 mm of buccolingual reduction is required. So everyone will have a doubt like whether we have to cut the occlusal first or proximal first. So according to the full et al., so he considered preparing the occlusal surface. Why? Because it first allows the better access to the proximal areas of the tooth. So other authors, they said that first we have to cut the proximal surface first, then we have to go for the occlusal surface. So placement of the separators, we can use the separators like wedges. So advantages of this using these wedges are better access of the reduced risk of the heterogenic damage to the adjacent particular tooth. So it also helps to depress the gingival tissue and rubber dam. So next coming to the selection of the size. So according to Spedding, he advocated 2 important principles which will help in produce the well adapted stainless steel crown. The operator must be establish the correct occlusal gingival crown length, and whereas the second one is it should be the shaped circumferentially to follow the natural contours of tooth marginal gingiva. So different sizes of the crown, it is available from 2 to 7 size. So you can see in the table, so there are different tooth with wide range of different sizes. So out of all these, only 4 and 5 sizes are mostly used. So next coming to the crown selection. So according to the Nikhil Mawa, so mesodistal diameter we will check first, then later check the occlusal height of the crown. So the different ways to select the crown is like first is trial error method, and second is measurement of the mesodistal width by the Bolli's gauge or vernier calipers. So adaptation of the crown, first we will see the gingival contour. So gingival contour of different tooths like gingival contour of the second molar is smile shape, and gingival contour of the first molar is stretchless shape, and proximal gingival contour of the molars are frown type. So next coming to the crown finishing according to the different authors, like reduce and round off all surfaces. According to the Matchison, we have to smooth and polish with the rubber abrasive. So next coming to the before cementation. So before cementation, all the authors are said like cavity varnish to be applied before crown cementation. Next coming to the materials used. So while in the vital tooth, you have to use like according to different authors, polycarboxylate cement, zinc oxide cement, and zinc phosphate cement. So everyone will have a doubt like how much cement to be filled in the crown. So most of the authors said like 2/3 of the crown should be filled with the cement, so that the excess material after cementation, it will come out and we can wipe it out. Next, coming to the seating of the crown. First, we have to seat the crown from the lingual to the buccal, and we have to see the crown fit. There will be a snap sound fit of the crown. After that, radiographic confirmation of the gingival fit we will confirm. Next, coming to the complications of the crown. So main complication is like inhalation of the crown and interproximal ledge formation, crown tilt, poo margins, under extension and over extension of the crown. Post cementation instructions: avoid heavy chewing with the crown for 24 hours and maintain oral hygiene, and the patient should be recalled for every 6 months for the follow-up of the crown. Next, coming to the different modifications of the stainless steel crown. So in first modification is undersized, second is oversized, and third is open contacts. So oversized crown or undersized tooth, with the help of the scissors, we will cut the crown on the buccal side. So we have to overlap the crown one over the other as shown in the figure. So after that, we have to spot weld the crown. So next is undersized crown and oversized tooth. So we have to cut the buccal side of the crown. Once we have to try on the tooth, so that it will be like as shown in the figure, it will be seen like V shape on the crown. So over that, we have to select a band material and round off the margins and place on the crown we have prepared. So after that, we have to spot weld it. Next, coming to the open contacts, we have to select the larger sized crown. So we have to exaggerate the interproximal contour. Next, coming to the modifications of according to the placement. So there are different types of modifications according to the placements. We'll see one by one. So first is adjacent crowns. So adjacent crowns we prepare both in the same visit. So adjacent proximal surfaces should be reduced slightly as like while preparing the single crown. So why? Because we have to cut the two crowns, right? So for that, we have to cut the excessive proximal side. So next, adjacent to the class 2 amalgam. So after first crown reduction is completed, after that crown is adapted, cementation of the crown next to the amalgam restoration with matrix band in the place. So next modification is adjacent stainless steel crown with arch length loss. So here loss of mesodistal dimension is seen, and we will prefer small size crowns. So next modification is before the eruption of the permanent molars. So care must be taken for the space needed for the eruption of the permanent molar. Multiple crowns in the same arch. So while doing this modification, adapt and seat the crown most distal to the first. For example, if you are doing the primary first molar and second molar, first we will try to adapt the second molar first. After finishing second primary molar, we will come to the first primary molar. Next, coming to the crown extension for deep subgingival caries. In this, the crown margin should be overextended. As shown in the figure, a metal piece or a band should be welded onto the crown where the gingival caries is present. Next, coming to the open faced stainless steel crown. This type of crowns will give mostly for the anterior tooth, where we'll for the aesthetics is the concern, where the patient or patient parent says, so we don't want this stainless steel crown. So for that, we will make a slight modification. That modification, we will create a window onto the labial side of the crown, so that over that we will place the composite restoration so that it appears aesthetically. So advantage of this is aesthetics. It is very durable and retentive. The materials are fairly inexpensive. The disadvantage is it will take time. It will take longer duration compared to the normal crown preparation or cementation. The placement of the composite facing may be compromised sometimes. Next, coming to the stainless steel crown technique for the anterior teeth. So here anterior teeth, the stainless steel crown, sometimes patients and parents will say like aesthetics is the main concern, so it is a stainless steel. So for that, we can do like a modification, like usually the stainless steel crown for anterior teeth will come in a ovoid shape. So we should we'll squeeze the crown slightly mesodistally with the help of the hoe plier as shown in the figure. So after that, you have to extend or create a window on the labial side. So once it is properly trimmed and contoured, and we have to place the undercuts at each margins with the help of a 35 burr. So over that, after that, smoothen the margins, and we have to finish with the help of the greenstone burr. So coming to the restoration of the hypoplastic tooth, in the case of the occlusal wear, so where the decreased vertical height you see, there you will have to add a layer of the solder from the impression surface. In case of the bruxism case, here also we will use this add the layer of the solder from the impression surface of the crown should be added in case of the bruxism cases. According to Kroll in 1982, modification for bruxism is, he advised patients with the tooth grinding habits may tend to wear through the occlusal surfaces. He advised like technique described which prevents this problem by increasing metal occlusal surface thickness of the crown as shown in the figures. So everyone will have a doubt like stainless steel crown can be used as a preventive measure. Yes, we can use that. There is a one technique which is called as a Hall's technique. So this technique is named after the Dr. Norma Hall, so who is a practitioner from Scotland, who developed and used this technique for over 15 years, and she retired in 2006. The crown is seated over the tooth for the Hall's technique with the, which is by not using this local anesthesia, caries removal, and tooth preparation is also not required. So the Hall's technique process of fitting crown, which is quick and invasive. So steps we will see for the Hall's technique is, first one is placement of the orthodontic separators so that the crown should go inside properly. Why? Because we are not doing any crown preparation here. So there will be a tight contacts. If you place the separator, there will be you can see the space between the two tooth. So step 2, selection of the small sized crown that covers all the cusps and approaches the contact points. Step 3 is adjustment of the crown using the band forming plier if it is required. And step 4 is cementation of the crown followed by removal of the excessive by using floss. So coming to the indications of the Hall's technique. So indications of Hall's technique is, first one is for class 1 lesions which is not cavitated, class 1 lesions which are cavitated, and class 2 lesions which are cavitated or non-cavitated. These are the indications for Hall's technique crown. Coming to the contraindications of fitting the Hall's crown. So this Hall's technique is contraindicated for the irreversible pulpal involvement, insufficient sound tissue, and a patient at risk with the bacterial endocarditis, patients or child who are unhappy with the aesthetics. Thank you all.